Boa noite a todos, sejam muito bem-vindos a mais esse encontro da Sociedade Brasileira de Pneumologia e Tisiologia. Hoje nós vamos estar falando sobre rastreamento de câncer de pulmão e dentro desse tema, que é um tema extremamente amplo, nós vamos abordar a questão de fatores ocupacionais. Vocês, obviamente, que estão começando a entrar em programas ou enviar pacientes para programas de rastreamento, vocês sabem perfeitamente que os critérios que assim originalmente foram é, elencados para colocar indivíduos dentro de programas baseado em idade e tabagismo são critérios extremamente importantes, mas outros critérios de riscos devem ser levados em conta. O critério baseado só em idade e tabagismo deixa de abranger uma parcela muito importante de indivíduos em risco de câncer de pulmão, e hoje nós vamos exatamente falar sobre a parte ocupacional e o quanto isso pode auxiliar vamos dizer, na escolha, na escolha de indivíduos para entrarem dentro de programas. O evento de hoje é uma iniciativa da Comissão de Doenças Ambientais e Ocupacionais e da Comissão de Câncer. Pela Comissão de Câncer da Sociedade, nós vamos contar com a participação da doutora Juliane Penalva, que já vai dar um alô para vocês. Eu sou Eduardo Algranti, no momento coordeno a Comissão de Doenças Ocupacionais e Ambientais da Sociedade. Passo a palavra para a Juliana antes de introduzir o nosso palestrante da noite. Boa noite, Juliana.
Boa noite,
Juliana,
Isso, Juliane. Boa noite, doutor Eduardo. É um prazer estar aqui com todos vocês. Obrigada pelo convite, né? Por essa interação aqui, falando sobre esse tema extremamente importante, que é o rastreamento do câncer de pulmão, né? Aqui no Brasil, a gente ainda está caminhando nesse processo, mas cada vez mais se construindo algo mais robusto nos serviços, né? E quem sabe logo mais de forma populacional mesmo, contando com a saúde pública. Recentemente foi publicado o guideline de recomendação da Sociedade Brasileira de Pneumologia e Tisiologia, né, sobre o câncer, o rastreamento de câncer de pulmão na nossa população em específico. Então, acho que isso vai trazer uma força muito grande para esse movimento do rastreamento do câncer de pulmão, que é algo tão importante realmente, né, pensando de forma populacional. E aí trazer esse tema um olhar específico para as doenças ocupacionais, que é um risco que também deve ser considerado na avaliação desse paciente, eu acho que é extremamente relevante. Vai ser muito boa a nossa discussão hoje aqui.
ótimo. Só lembrando a vocês, depois da apresentação do Dr. Steven Markowitz, nós vamos ter minutos para perguntas e nós pedimos que vocês coloquem as perguntas no Q&A, né, no QA e não no chat, tá? Isso aí é importante só para vocês não esquecerem disso aí. E, obviamente, esse encontro está sendo gravado e vai ser disponibilizado posteriormente. Bom, é com grande prazer que Juliane e eu introduzimos o nosso palestrante, o Dr. Steven Markowitz, que já é conhecido de longa data. O Dr. Steven estudou medicina na Universidade de Yale e depois fez a sua pós-graduação em Colômbia e ele é certificado em medicina interna e saúde ambiental e ocupacional nos Estados Unidos. Atualmente, o Dr. Steven é diretor do Centro de Biologia e Sistemas Naturais e professor de Ciências Ambientais no Queens College, na City University de Nova York. E é também professor adjunto de Medicina Preventiva na Escola de Medicina do Mount Sinai, em Nova York. E só para vocês terem uma ideia da experiência dele com o assunto, o Dr. Markowitz coordena o maior programa que engloba a inclusão de fatores ocupacionais no rastreamento de câncer de pulmão nos Estados Unidos, e recentemente ele liderou uma publicação que está no American Journal of Industrial Medicine exatamente sobre esse assunto, sobre a incorporação de fatores além de tabagismo e idade no rastreamento. E nós agradecemos muito ao Steven pela disponibilidade e é uma honra poder contar com sua apresentação hoje à noite. Com a palavra, Steven.
Okay. Okay, well, thank you, Dr. Algranti and Dr. Penalva. Thank you very much for the invitation to speak tonight, and thank you all for spending your evening listening and discussing these things. So I'm going to share my screen here. I'm going to talk about, in general, about the issues, but then I want to talk about, in particular, about our experience. And I think you all can see this okay? Or it's coming into, yeah, okay.
Yes.
So talk about our experience and maybe, you can save yourself some efforts by benefiting from some of our failures and how we've overcome our failures. So let me just okay, this is my disclosure. I have no conflict of interest. This work is funded by the United States Department of Energy. That's the department that does energy science and also takes care of created, produced, and made the nuclear weapons of the United States. And our program, we call it the Worker Health Protection Program, and it is a partnership between labor unions and the university. In particular, the Steelworkers Union. Now, that's the largest industrial union in the U.S. And secondly, the Atomic Trade and Labor Council. And those are mostly skilled trades, construction workers, carpenters, sheet metals, and the like. Many people contributed to this program over the years. So I just want to summarize some of the main points here. One is that once you start asking, you realize that workplace exposures are reasonably common. Not as common as smoking, but they are reasonably common. And interestingly, as you know, when you put workplace carcinogens together with smoking, the risk of cancer, especially lung cancer, is greatly amplified. It may not multiply, it may multiply, but at a minimum, it's above the additive risk. And the best example of that is asbestos in cigarette smoking. Thirdly, workers were at risk for lung cancer due to no fault of their own. They were employed in situations where they had exposures to lung carcinogens. They usually did not know that they were exposed to toxins that caused lung cancer. And that's different, say, from cigarette smoking, where people clearly participate in their exposure to cigarette-related toxins. And then finally, and I think on a practical basis, maybe the most important point is that the advantage of including workplace exposures is that you're more likely to make the screening a success. And I'll explain in our program what I mean by that. In the occupational world, thinking even specifically the occupational pulmonary world, do we ever have the opportunity to actually cure occupational lung diseases or any occupational diseases? So I normally ask this, and normally no one comes up with an answer. Occupational asthma, obviously we do not cure. We certainly don't. We can take people out of exposure. Occupational COPD, yes, there's some control, but no cure. Interstitial fibrosis, the occupational side, asbestosis, silicosis, we have no treatment for those diseases. It's really, lung cancer is really the first opportunity, and through screening, that we have to actually cure people from these diseases. And this is probably not the right audience, but I always include this slide. This is one of our early lung cancers we detected. And for the less informed audience, it's just so clear, the imaging is so clear that of the kind of results that are obtained. So in the US, lung cancer is especially important. It's our leading cause of cancer death. In fact, it's equal to, among men and women, the next 3 most common causes of cancer death. So breast among women, prostate men, colorectal. That's how big lung cancer is in the United States. And I looked at the Brazil numbers. Brazil has, in size, 2/3 of our population, only 1/3 the number of our lung cancer deaths. So you're much better off than we are in terms of lung cancer. I think you came late to the cigarette smoking epidemic, I think. But even in Brazil, lung cancer is the leading cause of cancer death in men, and it's number 2 in women. So numerically less important than where I live, but still very important. And in the occupational world, it's our most important occupational cancer. So I covered that point. Now I'm going to show you you got to give me probably 3 minutes to discuss the history of screening, because it's important to know how we got here. 25 years ago, Sohn in Japan, Henschke in New York City, just screened a lot of people, high risk for lung cancer, older people, smokers, and they found that they could detect lung cancers at an early stage. And then Henschke in New York followed her group for another 5 years and had an estimated 10-year survival of 92%. This was before the randomized controlled trials. And this was just published last year, the Henschke data. And this is the 20-year follow-up of that same group. And you can see the people who had very early stage disease and had prompt surgery. At 20 years, they had a 90+% survival. And even actually among all patients, 81% survival, 20 years later. So that's really long-term follow-up. And then we have the randomized controlled trials in the US, the NLST, National Lung Screening Trial, published over 10 years ago, 20% mortality reduction. And in Europe, the Nelson trial, again, a 20+% mortality reduction. So for people who needed a randomized controlled trial to give a definitive answer, we have that now. And so in the US, we needed a policy about lung cancer screening. And 10 years ago, and the importance of this national policy is it determines what insurance companies have to pay for, whether it's private insurance, public insurance. So in 2013, the eligible group was age 55 to 80, 30 pack years, less than 15 years since quitting. And then 2021, they reduced the eligibility to 20 pack years, the age to 50, and then left the smoking cessation untouched. Interestingly, the American Cancer Society just eliminated the years since quit. So if you quit 30 years ago, but smoked 20 pack years, ACS recommends that you be screened. So the 2021 change in criteria meant that there was a much larger population eligible for lung cancer screening. Now, current US policy, age and smoking only. That's all we look at in terms of coverage. But we've had 2 problems. One is even in the older smoker population, we've had very poor uptake of lung cancer screening. Hugely disappointing, very difficult to explain. And I hope you have a better experience than we have. And then secondly, in the occupational world, we can't seem to find people who have the occupational risk. They exist, but we have trouble finding them. So let's talk about this uptake problem. Well, uptake, I mean people who enroll in lung cancer screening. In the US, pretty much before the pandemic, we're talking about 20% of people who are eligible based on smoking and age would sign up for even initial lung cancer screening. So only 1 out of 5. And then when we expanded the eligibility, that dropped because the pool was much larger. And so we only have about, as of a few years ago, less than 1 in 10 people who are getting screened by lung. This is our #1 cause of cancer death, and less than 1 in 10 people are signing up for it. I want to compare this for a moment to screening rates for other cancers. I don't think I need to go through this. You can see breast, colorectal, high percentages of eligible people who are being screened, even prostate. We don't even recommend prostate cancer screening anymore, and it's at 40%. Lung, it's less than 20%, or maybe less than 10%. So why is it so slow? There are a lot of barriers. I don't want to go through these. Your mix of barriers to screening probably differ from ours. We have a hard time getting the primary care doctors to accept this. And I think a lot of individual people, in particular smokers, are reluctant to go for cancer screening. I think smokers are ashamed. I think they're afraid because they know what lung cancer means. And I think they're in denial. And so they don't go for lung cancer screening. One problem we don't have is where lung cancer screening is available. So the black dots, each is a radiology facility that offers low-dose CT for lung cancer. And you can see that the brown and tan states, those are states where the majority of people have ready access to lung cancer screening. We have no problem with accessibility, availability of radiology facilities. The radiology community has done a wonderful job in expanding services. The second problem in the occupational world is that there's a problem finding people who are at risk. Now, I don't know what it's like in Brazil, but here you can read general medical records, and this is what you usually see for the occupational history. And I'm sure as pulmonary physicians, this is what you see in the general healthcare system. Or even better, after people retire, when it's their highest risk of lung cancer, because it takes decades for the risk to go up, this is what we see. Now, these are from medical records of people with mesothelioma. So they have an asbestos cancer, and the doctors should be looking for the exposures. But the fact is that the healthcare system really doesn't recognize occupation, despite the fact that exposures are common. Here I recognize carcinogens, asbestos, more in the past, still with risk. Silica, still quite common. Radon, there is radon in Brazil. Diesel exhaust, welding fumes, and a bunch of metals. So, and then I just show you, you can look at it by industry, you can look at job title. There are ways of tracking workers who are at risk for lung cancer, and some pretty common job titles. So the question is, how do we broaden the risk factors that we look at? As I said before, officially, we only look at age and smoking, but even beyond occupation, family history of lung cancer, chronic lung disease, interstitial fibrosis, COPD, and the personal history of cancer. These are all real exposures that cause lung cancer. So I'm going to argue we should prioritize blue-collar workers because they smoke at high rates, and the highest rates of smoking are among such workers, and also they have workplace exposures. I'll skip over that slide for the sake of time and get to the program that we've been involved with over the last 25 years, the nuclear weapons workers. In the US, it's the only industry where workers after retirement are entitled to occupational medical screening. So we have plenty of workers, as you do, in the steel, chemical, pharmaceutical, refinery. Once they retire, they're entitled to nothing in terms of medical attention for occupational disease. This group of workers, the government decided, deserves a screening program. And I won't go through the language, but just to give you a sense, this is on the left is Tennessee, one of the facilities where we screen the workers. That's an enormous plant that enriched uranium. On the right is the first test reactor, still exists in Hanford, Washington. This is a gaseous diffusion process. One of the fun things in occupational medicine is getting into workplaces and understanding what people do. Here what we did was take uranium, make it into a gas with fluoride, and send it down these cascade, these tubes where they would separate out the isotopes. Here's a strange, this is from Nevada, just up north of Las Vegas, where the US tested atmosphere in the 1950s, tested weapons. And this group of people is an advisory board I serve on for the Department of Labor for compensation. This hole we're standing in front of, they tested a nuclear bomb. They wanted to see if they could use it to dig deep holes so they could go into ports and make the port deeper to handle bigger ships. So they had this idea they could use this for civilian purposes, but I'm happy to say they gave up on that idea. This is where we're conducting our program in over the last 25 years, the Midwest, Ohio, Kentucky, Tennessee, and out in California, New Mexico. And we use worker coordinators. We're in New York, but these are the people who are the face of our program in all of these mostly rural communities. That's how we make this program work. So when we read Henschke and Yankelowicz's study in 1999, we had just begun our screening, our general screening for these workers, and we decided that we should offer lung cancer screening. And so in the history, right after we learned of this, we initiated low-dose CT. So we've now had almost 25 years of experience. And this was our opening with politicians, of course, who rightly claimed credit for helping us begin the program. This is our first mobile unit. No one did low-dose CT. So we had to have our own mobile scanner. And as opposed to the National Cancer Institute study, which was in Baltimore and Detroit and New York and Houston, we were in the rural parts of the US testing out lung cancer screening. And this is the states we were doing this with our scanner, running it between Ohio, Tennessee, and Kentucky. And when I showed this to the people I work with who were doing this, all the logistics, they made me add these are the women in the left who did this work. They reminded me that running a mobile unit is a real pain. It's difficult. It's gotten easier now, I think, with wireless, with generators, but it's challenging. And now we have our current scanner, which is parked in front of the Union parking lot. We don't move it, and we scan a lot of people. So who are we scanning? Nuclear weapons workers, rural areas, age, smoking, occupation, and all of our scans are sent online to one reader in New Jersey. We now buy, mostly in most of our places, we buy services from radiology facilities, except in that one place where we have a scanner. And these are our eligibility criteria. The specifics are not important, but I want to show you some of our results. So I said before, the uptake in the general smoking population is 10%, 20%. In our program, large numbers, 2/3 of the people enroll. So we get much we would like to be higher, but we have a much higher enrollment rate than in the general population. And these are our results over 24 years. We've screened 14,000 people. We've detected 217 lung cancers. And most importantly, 73% are early stage disease. And interestingly, this is the same result that the National Lung Screening Trial had, about 70% early stage cancer. This is not a careful randomized controlled trial. This is community-based screening in rural areas with community follow-up. And yet we got the same result. And what that means is that bringing it out of the careful academic medical centers into the real world, this is a very robust technique that's going to detect early lung cancers. And so I think for the sake of time, we demonstrated here that when you add occupation, you can lower the pack years. So before it was 30 pack years, we used 20 pack years because people had occupational risk. Now the recommendation is 20 pack years. We use 10 pack years, and we have no time since quit criteria. So we're scanning people age 50 and over, 10 pack years, no time since quit if they have occupational exposures. So, but it's important that people pursue annual screening. And I took a look at what's published, and in 15 studies, the average adherence to the first scan, people were enrolled, they had a baseline scan. Did they come back the next year? Only 55% came back. And that's not satisfactory. And so in our program, and here I introduce our notation, T0 was our baseline scan, T1 first annual, T2 second annual. And so we looked at our adherence, and you can see 1,300 people. And in the second column, did they show up on time for their first annual scan, second annual scan, et cetera, T1, T2, T3. And you can see that we had over 80% adherence to the scan. I think we get that because we're aggressive about pursuing people, and because I think when the occupation is considered as part of the screening mix, I think screening is more acceptable to people. I think in part because they don't feel blamed, they don't feel that they're at fault, even though they're all smokers, right? But still they have this occupational piece that ropes them into screening. And it's important to keep screening. I show you our detected lung cancers at the different Ts. So look at T4, T6, 22 lung cancers. That's more than even at baseline. And the T7, T9, we don't have that many people yet who've entered T7, T9, so it went down. But you've got to keep screening. And if you keep screening, you'll continue to find lung cancers. And the question then is, what stage are they at these as time moves on in the program? And here at our baseline, we had 59% who were early stage disease. And it was the first annual, second annual, third annual, it was about 61%, unchanged. Interestingly, T4 to T6, we were up to 76% early stage disease. Now, I don't know if we have numbers to show that there's a true elevation in percentage, but it means that the effect of finding early disease continues well into a mature program. So it's a lot of effort to get people to come back. They will come back. And when they come back, they and you will be rewarded by continued diagnosis of early lung cancer. By the way, there aren't that many programs that have followed people this long to show these kinds of results. And so we looked at, and Dr. Algranti was part of this effort, an international group. We looked at how to think about who should be at risk, and we came up with the only international consensus statement about lung cancer screening. And we basically encouraged, and people were from North America, from Brazil, from Germany, from South Africa, and Canada, and the like. And so you can read this, it's available online, but it basically says, consider a broad set of risk factors in order to, and there are lung cancer calculators that let you do this. You can put in your various risk factors. We haven't found one that actually addresses occupational factors adequately. There's a couple that include asbestos, but they don't look at any other occupational factors. And they aren't as inclusive of all the factors that should be looked at. But clearly, it needs to be broader than just age and smoking. And then the question is, how do we make this happen? And I really can only say that we're struggling with this in the US. In the occupational world, it's challenging. The employers aren't going to be interested. They don't want to pay for it. They don't want to get into lung cancer risk among employees. Frankly, the biggest risk for workers is 20 or 30 years after exposure. So you're talking about mostly people who are retired. And after retirement, the worker has no relationship with the employer. So even if the employer were interested, it wouldn't happen. The healthcare system, as I alluded to before, doesn't really do a great job at identifying occupation or related risk. And then labor unions would be interested on behalf of their members. In our country, very few people belong to unions. It's about 10%. And then frankly, when I approach the unions, as I have about this, beyond the unions that we work with, it's difficult to convince them, not because they're not interested. It's just they have a lot of competing priorities. They have other things they are concerned about relating to healthcare, and the kind of health attention their workers should get just is not high on their list. So this is and then there's regulation. Our government, for people exposed to asbestos or silica, they have required medical surveillance from the employer, but so far the required medical surveillance does not include lung cancer screening. So regulation really hasn't been the solution to our problem. So in the occupation, and then finally, the idea I have is, since we use electronic medical records all the time, is if in the record is the age, right? And in the record is the smoking history. And usually it would be the year quit smoking if they quit. So you could add the usual job title or the usual occupation to the electronic medical record. And then the algorithm could tell you who's at risk, including age, smoking, and occupation. Obviously, you could do this with family history and with chronic lung disease also. It's a bit of a challenge on the occupational side, translating simple descriptions of job titles into who's at risk. Some are obvious: carpenters, chemical workers, concrete, cement workers. But there are others who are, it's not so obvious. So that's a challenge. So frankly, this is a nut that we haven't quite cracked, but it's something that we're trying to figure out. And so these are my final thoughts, and then we have time for questions. in my experience, the healthcare systems, they largely ignore occupation as a disease risk factors. Doctors aren't really charged with causation. We're charged with diagnosis and treatment. And unless causation impacts diagnosis and treatment, frankly, it becomes a curiosity, but it's not important. And I have to say, I don't think that's changed in the last several decades. In our country, we haven't been any more successful at convincing primary care doctors to factor in occupation. Pulmonary is, I think, maybe different, but I'm not sure whether it's entirely different. If we are going to go out and target lung cancer screening, the people who make most sense, are people of a certain age who smoke, because that's the strongest factor. But in addition, have occupational exposures, because those are the same people. The heaviest smokers are also the people who have, many of whom have the occupational factors. I mentioned that we're going to need specific efforts to address this issue. And then finally, I think we have to somehow, and I think it's more as much a public health issue as it is a clinical consensus issue, is figure out how to motivate people to go for lung cancer screening, because we have this ability to detect cancers where straightforward thoracoscopy can remove the cancer, and the person goes home the next day or the day after with no adjuvant treatment, no additional chemotherapy, immunotherapy, radiation therapy, and then have a normal lifespan. For in our country, the #1 cause of cancer death. And astonishingly, we're not really convincing people or the healthcare system to adequately do this. So I think that we have a challenge. I think, those of you who are a little bit younger have, you have some work to do. Something important to do over the next couple of decades is to solve this challenge. So thank you very much.
Steven, muito obrigado pela sua apresentação. Eu vou falar em português para a audiência entender com mais facilidade. E, enfim, eu obviamente já conheço muito daquilo que você falou, e eu anotei alguns pontos para discussão aqui, que eu considero importantes. Eu não estou vendo ainda nenhuma questão colocada pela audiência, e eu queria passar a palavra primeiro para a Juliane, se você puder.
Boa
Isso.
noite. Obrigada pela apresentação do Dr. Steven, foi maravilhosa. Eu queria abrir com uma pergunta, posso, Dr. Eduardo? A gente viu, então, que a exposição ocupacional é um fator de risco importantíssimo, né, para o desenvolvimento do câncer de pulmão, e na nossa prática de pneumologia, realmente a avaliação, principalmente a gente que faz doença pulmonar intersticial, né, essa investigação da questão ocupacional acaba sendo bem frequente na nossa anamnese. E aí a minha pergunta seria, quanto tempo de exposição a gente considera que é relevante para incluir o paciente no rastreamento? O paciente fica quanto tempo em disposição no trabalho para ele ser incluído nesse projeto de rastreamento?
Well, it's all about dose, right? It's all about how much exposure. And the easy part of that answer is the exposure needs to occur at least 15 years previously, right? Because the risk doesn't increase for at least 15 years. And in our program, we use 2 years. We're starting up a new program in Los Alamos, New Mexico, where we have more specific information about asbestos exposure, beryllium exposure, and we're going to use 1 year, a minimum of 1 year of exposure to asbestos or beryllium, which is a metal that causes lung cancer. Obviously, dose depends on intensity of exposure, frequency of exposure, and duration, right? So what you asked about duration, and we usually don't know in general frequency or intensity. Intensity is how much, but how many fibers per cc, etc. And so we need a shorthand way of approaching this. And I would say somewhat 1 or 2 years of exposure. Now, mind you, most people who do this kind of work, construction work, manufacturing, they don't do it for 1 or 2 years, right? Construction workers, they usually stay in construction. So it's unusual to have the question of the person who only has 1 or 2 years of exposure. I don't think epidemiology really helps us that much because the studies haven't been large enough to really drill down into that detail around the number of years. You can do a risk assessment and look at how increasing dose relates to increasing risk. It gets complicated, but at some point you have to decide, whatever model you're using, you have to decide what level of risk you're going to screen at, right? And then you get into, well, what are the benefits? And the way I look at people who are, we have our criteria, and then we have people who don't meet our criteria, but they want to get in. They want to be screened. And so I look at all the risk factors, and I sort of weigh them, and then often let them into screening because they have enough risk factors, even if I can't put a number on it. So the short answer, and I'm sorry, such a long answer, but the short answer is, I think 1 year, 2 years is reasonable, but I think for the job titles that you're going to be aware of, usually they will have many more years of exposure than that. Eduardo, did that answer make sense?
Sim, faz sentido. Algumas coisas são interessantes a gente pontuar aqui. A experiência, e eu acho que você estava falando muito em relação à questão da exposição ao asbesto, né? E a experiência norte-americana em relação à exposição ao asbesto, ela é muito diferente da nossa aqui, embora a utilização tenha sido muito grande, nós temos uma quantidade de asbesto espalhado no país imensa. Nós não tivemos, vamos dizer, os riscos que tiveram nos Estados Unidos, por exemplo, onde se utilizou muito asbesto para isolamento térmico de construção. Aqui o que a gente usa em construção são mais materiais de cimento, amianto, que são, vamos dizer, o risco de exposição é menor do que um asbesto em spray. Então, essas coisas todas. Por outro lado, para aqueles trabalhadores que se expuseram ocupacionalmente, as condições de trabalho aqui no Brasil, comparativamente a países desenvolvidos, obviamente, assim, na média, são piores. Então, tem um balanço aqui que nós precisamos ter sempre em mente. A sua resposta bateu muito em relação a um documento que foi recentemente publicado na revista, no Jornal Brasileiro de Pneumologia, saiu no mês passado, onde nós estamos propondo que indivíduos que tenham pelo menos um ano de exposição, isso especificamente em relação ao asbesto, 20 anos de latência com eventuais queixas respiratórias, passem por uma tomografia. Isso não é para, vamos dizer, para se buscar câncer de pulmão, para se buscar mais doença intersticial, mas cai exatamente dentro daquilo que você falou. Então faz muito sentido, sim. Eu concordo que é um número empírico, não é baseado em nenhum estudo científico, mas nós estamos usando um critério para a doença intersticial inicial, que é muito similar.
Obrigada. A gente tem uma pergunta aqui no chat, doutor Eduardo. Ana Paula Scalha perguntou se existe algum estudo que tenha feito rastreamento em pacientes com riscos ocupacionais, mas não tabagistas. Doutor Steven.
Yeah. So, yes, very limited. We actually, before the United States had recommended criteria, 2006 to 2010, in this program, we screened 4,000 never smokers. So they met the age criteria, and they all had some occupational risk, but they never smoked. 4,000, so that's a lot. And we found 6 lung cancers. So that's, 1 out of every 650. And otherwise, we found about 1% with the smokers. And the big national lung screening trial was about 1%. So we decided that the yield was too low to justify screening. There have been in Finland, they have, Finland and also Australia, they have screened some never smokers, but a small number, and they have been exposed to asbestos. And I think all of them had scarring in the chest, either pleural or parenchymal disease that they screened. And they did find some lung cancers. But the numbers in the various studies are too small, really, to generalize. I think in China, they are screening a lot of people who are relatively young who never smoked because they have a problem with adenocarcinoma, in particular among women and who are younger than age 50. And so, and they have a lot of scanners. And so they're starting to scan people. So it's a really interesting question. How much risk do you need, right? And so one of the questions for the future, which you all can work on, is if we lower the dose of the low-dose CT further, then we don't have to worry about the radiation risk. So right now, the low-dose CT is about 8 times the chest X-ray in terms of dose, about 1 to 1.5 millisievert. And chest X-ray is closer to 0.1 to 2.2. And so if we can get ultra low dose CT, so we don't have to worry about the radiation, there's the issue of cost. I get that. But then instead of surveillance with chest X-ray for non-malignant disease, we can do surveillance with ultra low dose CT and look for non-malignant and malignant disease. And the people in Australia have used ultra low dose, in which they basically just turn down the dose on the CT, on the scanner. It's a advanced Siemens scanner. And it's about 2 times that of a regular chest X-ray. And they have found they've gotten good results. So we're trying to do that, but we have a hard time finding a community that's interested in this. The radiologists don't really care about lowering the dose because low dose is low for them, right? And they're also concerned about image quality. So, if they get good image quality at low dose, then why try ultra low dose? And in general, the problem is getting people to come in at all for lung cancer screening. So I don't see a real drive to lowering the dose, but in the occupational world, it would be wonderful because we could do away with the chest X-ray, use ultra low dose, and look for the interstitial fibrosis that Dr. Penalva, you're interested in, the lung cancer that Dr. Algranti is interested in, all with a single scan. Sorry, long answer to a short question.
Ok. Eu tenho algumas questões também. Eu queria uma curiosidade. Se fossem adotados, vamos dizer, os critérios da NLST no trabalho que vocês fizeram nos indivíduos rastreados de plantas nucleares, quantos casos de câncer seriam perdidos, eventualmente? Ou até o inverso?
I see. Yeah, I understand. So yeah, we've never actually looked at that. There's a sister program of construction workers in the U.S. In the same Department of Energy world, and they do lung cancer screening, a much smaller program, and they've looked at that in particular, and if they use stricter criteria, the original NLST criteria, they would lose at least 50%. In other words, they would fail to detect 50% of the lung cancers. And it's, obviously that would be a harmful situation. NLS, in the US, they've lowered it to 20 pack years, so that helps. And that program, and we've lowered it to 10 pack years. We haven't quite figured out how to lower it to 0 to the never smoker. I think you could make the argument that the never smoker worker who had significant occupational exposure, that it should be up to them to decide whether they should have a low dose CT. In other words, we can't recommend it medically, but if they had a family history of lung cancer and occupational exposure and they're 65 years old, that's a reasonable request for low dose CT. And that's why, obviously there's the cost, I get that. But that's why ultra low dose is so interesting, because if you could do away with the radiation risk, which is not high, okay, it's low dose, but if you could simply erase the radiation risk, then it comes down to cost and incidental findings. Anyway, yeah.
Perfeito. Tem um ponto na sua apresentação que eu acho que é uma coisa muito interessante, a questão da aderência ao programa. E você fez a seguinte menção, que a aderência, eventualmente, quando se coloca um fator diferente de tabagismo e idade, pode melhorar. E isso possivelmente tem a ver com a questão de risco. O cigarro, ele é uma decisão individual, né? O fato do indivíduo fumar, ser um tabagista, é uma decisão que está sob controle do próprio indivíduo, né? Ele decide começar a fumar, continuar fumando. A exposição ocupacional, não. A exposição ocupacional, ela frequentemente ela está fora do controle do indivíduo. Ele não tem controle sobre isto. Então, o fato de você colocar um fator que o indivíduo não controla, ele pode eventualmente ser um motivo de melhor aderência. Ele fala, peraí, isso aí não foi culpa minha. Eu queria que você, qual é a tua impressão sobre isto?
Yeah, yeah. No, I think that is a key point. You know, when I think about the smoker, longtime smoker, current smoker, 65, 70, and convincing that person to go for low dose CT, you know, that person has to be willing to accept that, you know, their smoking might have harmed them. I mean, really accept that. They have to accept that they might go in for a test that takes 2 minutes and learn that they have lung cancer, which, as far as they know, is a completely deadly disease, right? And then they have to overcome their shame that they did this to themselves. That's, to me, those are huge obstacles. And I think the advantage, even among smokers, is that when you add the kind of risk that you're mentioning that was not under their control. So it's not a source of shame. There may be still the element of fear, but they didn't do to themselves. And in fact, they, as a matter of social justice, they are owed this kind of screening. That I think that's part of the reason we have, 85% adherence. Now, I think there are other elements where we work with the union. It's a whole program. Our people are very insistent about getting people back. We try hard. We don't say, call us back in a year. Should you remember? We're writing them letters and calling them, etc. It's a program, and maybe at some point, like mammography or like colonoscopy, you won't necessarily have to bother people as much, but right now you've got to bug them. So it's a number of factors, but I think this issue of where the risks come from is a key issue. And it's in terms of education and motivating people. It's a method that we can use to get people to come in. And I think for me, the issue is how to implement it. That's the challenge. How do you do it? I think we have to do it as a public health campaign, because the employers, the unions, the healthcare system is not super interested. So I think there's a public health aspect that we need to pursue. But maybe in Brazil there's different methods. Does that address your question?
Sim,
Yeah.
sim. Porque isso é uma coisa que assim, é um aspecto que eu acho assim de grande importância, né? Essa questão do trabalhador ter um risco, seja ele qual for, né? E não ter grandes possibilidades de controlar, e isso ser um fator, né, que possa movê-lo a fazer um controle um pouco mais estrito na questão de saúde. Tem diversos interesses envolvidos, é claro, né? Não é só o interesse pessoal dele de saúde, tem interesse social, econômico, legal envolvido, né? Agora, assim, um outro ponto da tua apresentação que para mim foi muito interessante, é o seguinte: vocês começaram antes dos grandes trials aparecerem publicados, né? Isso começa no final da década de 90 e vocês conseguem um resultado muito similar àquilo que foi aquilo que foi obtido nos trials, né? A minha pergunta agora é a seguinte: depois desses anos todos de experiência, vocês continuam fazendo o rastreamento neste grupo de trabalhadores e houve alguma mudança de critério depois que vocês analisaram os resultados?
Yeah. Yeah, yes, we liberalized the criteria. We reduced the pack years from 20 to 10. We have lowered the age from 55 to 50. We used to screen people even over age 80 because, say, men in the United States, 80 years old, average life expectancy is 8 years. So we thought that was justified. Now we're a little more careful after age 80. But the occupational risks we've pretty much kept the same, a minimum of 2 years. We have started to factor in the other risk factors a little bit more seriously. So family history, not radon because we can't measure it. I mean, we don't have the information, but family history, personal history of cancer, and in particular COPD, because COPD, above and beyond the cigarette smoking, adds to risk of lung cancer. So you take two smokers, one has COPD, one doesn't. The one with COPD, the same level of smoking, and the one with COPD has an increased risk of lung cancer. So you factor that into. So we're factoring in all those things, which we didn't previously do. And as far as starting it in 2000, before any real trials, our thinking was that the workers deserved a choice. That there was, after Sohn and Henschke published their studies, there was enough information. It wasn't definite, but there was enough information that we thought that the people at risk should be allowed to choose. It was an ethical issue. And that we as medical professionals didn't have the right to sort of impose our paradigm and our threshold for them. It wasn't clear cut, but I thought it was a matter of ethical, particularly since their risk, they didn't do this to themselves. You know, it was work-related risk. So that's why we thought it was ethically justified to do that.
Ótimo, perfeito. Juliane, algum comentário, perguntas a mais?
Não, foram considerações excelentes. Eu acho que só comentando um pouco da dificuldade do rastreamento, considerando a questão ocupacional, a exposição ao asbesto e à sílica, aqui no Brasil, acho que a gente enfrentaria ainda um problema maior pela falta de regulamentação de vários trabalhos que envolvem essas exposições, né? Aqui na Bahia, por exemplo, a gente tem muita mineração artesanal que não tem vínculo empregatício nenhum, e o que dificulta ainda mais, né, essa procura, essa busca ativa, tanto de doença intersticial, secundária à exposição, quanto, imagino, que doenças oncológicas.
Então, você está levantando um problema que para nós é o grande problema, que é a questão da exposição acílica. E assim, eu não conheço, e até perguntaria para o Steven se tem algum trabalho de rastreamento em populações expostas à sílica, mais especificamente, né? Isso é uma coisa que para nós é muito importante, muito bem lembrado.
No, I mean, the construction workers here, they were many exposed to asbestos, but a lot of them had silica exposure. Not to the point of having silicosis, but they still had some level of silica exposure. But the short answer is no. There's no study of silica exposed workers.
Isso talvez seja um tema para baixo da linha do Equador, né? Para ser desenvolvido por aqui. Muito bom, já são 8 horas.
Yeah, absolutely. Silica is probably the most common current exposure worldwide among the lung carcinogens, occupational lung carcinogens. There's diesel exhaust, maybe welding, but silica is the highest percentage.
Perfeito, muito bom. Steven, já são 8 horas e 7 minutos, aqui 7 horas e 7 minutos em Nova York. É hora de encerrarmos já e agradecer muitíssimo pela tua disponibilidade, generosidade em compartilhar com os, vamos dizer, não só com os teus conhecimentos, mas com a tua opinião, né? Assim, não tem gente que tenha a sua experiência, vamos dizer, nesse tema tão vasta. E, enfim, eu acho que foi uma contribuição para nós, foi enorme.
Well, I just want to thank you all for inviting me and also for listening, because I know you're in the position to do something about this, to figure out this puzzle. And it's, Brazil is such an important country, and with so many workers, a different environment than we have here, and hopefully you can do a better job than we're doing.
Difícil, mas não falta boa vontade. Então, Juliane, palavras finais.
Thank you.
É isso. Queria agradecer a participação, a oportunidade também. Espero que tenha sido proveitoso para todos. Foi bastante proveitoso para mim. Obrigada, doutor Eduardo e doutor Steven. Boa noite.
Okay, thanks, Steven. And
Okay.
enjoy the rest of your evening.
Okay, you too, y'all. Bye. Good night.
Bye-bye.
Boa noite.